Well, thank you all for joining us today at the University of Michigan-Flint Center of Aging Third Fall Symposium. My name is Cheryl Gurdon. I'm an assistant professor in the School of Social Work here at University of Michigan-Flint and co-director of the Center on Aging here. I'm so pleased to welcome all of you today. We have faculty and students from University of Michigan-Flint here, other universities across Michigan, as well as community providers across Michigan. Thank you for joining us for this very, very important topic, addressing social isolation and loneliness among older adults. Before we begin with introductions of our guest speakers, I just have a few announcements to make. I'd like to thank the Harand family and the Ben Breyer Foundation for funding this symposium. The Ben Breyer Foundation provided initial funding for the Center on Aging at University of Michigan-Flint, and we are very grateful for their support. I'd like to thank the Center on Aging leadership team for their key roles organizing this symposium, as well as Sarah Baker, creative support, Helen Garbarino, communication specialist for CHS. Just to review for today, the schedule, we will have a break from 10:30 to 10:45. After the break, Anna Church from the Zillion Solutions is going to kick us off with a little discussion about the Zillion Solutions contest. We'll continue with our guest speakers, Dr. Berg-Weger and Dr. Zubatsky, as well as community panelists, Katie Garvey and Patty Kearns, who I'll introduce later. And then we'll conclude with final remarks with Dr. Ken Sylvester, Interim Director at University of Michigan-Flint Office of Research and Economic Development. Please note, especially for people who are here virtually, there'll be information on a QR code. It'll connect you to a tree link with a few items. There'll be a certificate of attendance for anybody who needs that. There'll be a Google form that's going to be requesting data regarding those who are attending. This is voluntary to complete. Dr. Berg-Weger and Dr. Zubatsky's work is funded by the Health Resources and Service Administration's HRSA, Geriatric Workforce Enhancement Program. And the data requested is what they're required to report on an annual basis. We will share this data with them only for the purpose of their HRSA report. And again, it's voluntary to complete. The third item on the tree link includes a few outreach flyers regarding adult research projects that are happening at University of Michigan-Flint. So those of you who are connected with older adults, either in your life or your personal life, who you think might be interested in participating, thank you for sharing those outreach flyers to them. We'd like to acknowledge that the land the University of Michigan-Flint occupies is the ancestral, traditional, and contemporary homeland of many Indigenous nations. Most recently, the Anishinaabe, including Potawatomi, Chippewa, Ojibwa, and Ottawa tribal nations. We acknowledge the painful history of genocide, forced relocation, and removal of many from this territory. We honor and respect the many Indigenous people, including those of the Three Fire Alliance, who are still connected to this land. For the program today, Dr. Vivek Murthy, the U.S. Surgeon General, lists social connection as a public health priority and states that loneliness and social isolation is a significant threat to individual and societal health and wellness. We know that building and strengthening social connections is important for people of all ages, but that multiple barriers may impact social connections for older adults. Finding creative ways to help reduce these barriers may be one key to building and strengthening social connections for older adults. Our guest speakers, Dr. Marla Berg-Weger and Dr. Max Zubatsky, have joined us from St. Louis University to delve into this very important topic. Introductions. Dr. Berg-Weger is the Executive Director of the Gateway Geriatric Education Center in the Division of Geriatric Medicine, School of Medicine. Her scholarly work is focused on family caregiving, non-pharmacologic interventions for persons with dementia, loneliness and social isolation, age-friendly health and behavioral health care, driving in older adults, and social work practice. She has authored 4 books, 2 in the 6th edition, and over 100 publications. She's past president of the National Association for Geriatric Education and the Association for Gerontology Education and Social Work, and chair of the Gerontological Society of American Social Work Research and Policy Practice section. Dr. Max Zubatsky is the associate professor and program director in the Medical Family Therapy program at St. Louis University. He's a licensed marriage and family therapist and state-approved supervisor. He received his doctorate in marriage and family therapy from the University of Minnesota and postdoctoral fellowship from the Chicago Center for Family Health and Medical Family Therapy. Dr. Zubatsky is the director of the St. Louis University Aging and Memory Clinic and the associate director of the Geriatric Education Center. His clinical research interests include family caregiving, social isolations, interventions for dementia, integrated behavioral health, and burnout issues of healthcare providers. Thank you both very much for being here today. I turn it over to you. Thank you.
What Dr. Groden did mention is that we've known each other for
16 years.
Yes, through our connections in the Association for Gerontology Education and Social Work and Gerontological Society. So we are, on behalf of colleague Max, we're thrilled to be here. Welcome, especially to our virtual participants. Want to make sure that you are included in everything. So please put any questions that you have in the chat box. And as Dr. Groden said, we have been engaged in this work, interestingly, since summer of 2019. Everybody knows the significance of what followed a few months later. Let me just dive in, and please do feel free, raise your hands for those of you here in the room. You have questions, comments, and again, those in online, please put those in the chat box. We'll stop kind of at the end of each of our sections for questions as well. So, here we go. Yes, there we go. As Dr. Groden said, we are funded through Department of Health and Senior Services, Health Resources and Services Administration, the Geriatric Workforce Enhancement Program grant. And our university has had this funding for over 30 years, and we are focused exclusively on geriatric education. The emphasis has really shifted in this past funding cycle to really reaching out to all of you who work with older adults, regardless of discipline, work, educational level, because there are fewer and fewer people, unfortunately, who are specializing in working with older adults, particularly in the medical field. So thinking about loneliness and social isolation, I want to provide some context for it, but also the caveat that we do not consider, nor is it considered in literature, that loneliness and or social isolation is a mental illness or considered to be a diagnosable mental illness. More on that later, but it's certainly linked, and I think it's important to make sure that we've got the context for that. So just a few slides here to set the stage in that respect. So behavioral health challenges, including mental health as well as substance use disorders, are actually lower prevalence in older adults than for other segments of the population. However, and I'm sure all the who work with older adults can attest to this, can have greater impact. So that's why it's particularly important when we talk about loneliness and social isolation to be thinking about that. The pandemic, which we'll come back to as well, had a significant impact on all of us, of course, but 25 to 30% of older adults have been studied, and the studies are pouring out now about the impact of COVID on older adults, did report that they've experienced mental health challenges since the onset of the pandemic. But take a look at this next bullet point. Less than 50% of those people get treatment of any kind. So that's something that you're going to hear as a recurring theme throughout our talk, is that it's the issues of stigma, access, and comfort, to be honest. Compared to other high-income countries, US older adults are more likely to report, but again, less likely to seek care, and they tend to skip treatment, oftentimes due to financial or material hardships. And then, of course, as it says here, there are certain segments of the older adult population, like ex-elders, for instance, who do have higher levels of depression and mental health disorders. This last one is particularly concerning. You can see here that only 11% of those people who are on the Medicare recipient list receive treatment for substance use disorders. And we know that there are some points in time as we age where substance use and abuse do increase. So what are the risk factors? Long list when you think about mental illness among older adults. I'm not going to talk about the list, but do want to obviously draw your attention to the fact that kind of right in the middle there, experiencing loneliness and or social isolation can be linked to and can be a risk factor, and more to come on that one. So as we think about mental health challenges across the spectrum, what do we know? Well, I've already alluded to the fact it's underreported, undertreated. Many people, including many professionals, sadly to say, see loneliness and or social isolation and or mental health issues as normal aging. So that's an issue we all have to address. We have to make sure that, you know, the ageist kind of attitudes that are sometimes prevalent are being addressed. Lots of lack of awareness around the issues, mental health issues and loneliness and social isolation in particular. And then being able to separate out all of these risk factors. I'll come back to these issues. So what do we need to do? We need to do exactly what we're doing here today. And that is making sure that all of you are aware and have some information and tools to move forward. We need to remove the financial barriers to getting treatment. We have to address the unmet social needs and the disparities that exist. And we need to make sure that we are observing, screening, and intervening when we see issues. So shifting now to talk exclusively about loneliness and social isolation with that sort of backdrop. Let's talk first about prevalence. This quote was from, I think, the first loneliness and social isolation webinar I participated in during COVID, and this person's the CEO of this health group, and he said it's an epidemic in plain sight. It's there. It was there before the pandemic. It's increased during the pandemic, and it's still here. So we need to acknowledge that. It's important to start any discussion or educational event making the distinction between these words. They get used synonymously all the time, and even in the literature, you see them used, and you can tell if you read, they're being used, you know, to describe the other experience. So think of it as loneliness is a qualitative or subjective experience for people. It's when our expectations for the social relationships that we have or want to have are not meeting the reality of that or the person's self-perception. So it's very qualitative in that sense. Social isolation, on the other hand, could be, you know, thought about from the more quantitative perspective. It's number of contacts that people have. You can be both at the same time. You can be isolated and lonely. You can be isolated and not lonely. But it's an important distinction to make, that they are really separate experiences. They come from different places, and some people have posited that they should be treated differently. I think the jury's kind of still out on that one. Okay, so we have an older adult here, and there is no right or wrong answer, but just glance at him and wonder, you know, we're obviously here talking about loneliness and social isolation. When you saw this picture, did you think he was lonely? Is he not? Do you have any thoughts on that? And again, no right answer. I'm going to talk a little bit longer and I'll show him again, see if you have any different or the same thoughts. And the reason we show this picture is because we make assumptions when we see older adults, and we attach that assumption to our interaction with them. Food for thought. So, Dr. Groden mentioned Vivek Murthy, who was, and again is, the Surgeon General, and this has been a real passion project for him. In fact, he wrote a book. It's up here in the corner, published in 20, very timely. And he has referred to this as a global health epidemic. So this is an issue across the globe. It is not just a US-based issue by any means. National Academy of Science, Engineering, and Medicine came out with this, what has become a really landmark document in February of 20. And they referred to loneliness and social isolation as a major public health concern. In fact, these issues have been studied since the 60s. I have to confess, no awareness of that. I've dealt with older adults, of course, in my practice years, certainly talked about, focused my academic career on older adults, never really incorporated these issues of loneliness and social isolation. Want to just kind of provide kind of a more age continuum kind of perspective. Cigna periodically does studies of somewhere in the realm of about 20,000 adults, and looking specifically at this issue. So here you can say 58% of adults are lonely, based on their 2022 surveys. Those with mental health challenges, 2 times more likely than those who do not experience mental health challenges. Persons of color tend to be higher in these areas than when compared to all older adults. Those with lower income are also at higher risk. But look at this one, 18 to 24-year-olds, twice as high on the loneliness and social isolation measures than older adults are. And we could probably have a whole webinar on that issue, but that's not what we're here to talk about today. I think we all, can imagine some thoughts. Social media has always comes up as an issue for this particular explanation. Males and females are in the same range, and we'll talk a little bit about the gender distinctions. But there is a significant loss to productivity and increased absenteeism across the employment sectors, and it costs employers $154 billion a year, it's estimated. So looking at specifically loneliness in older adults, prevalence rates are all over the place. You can see here, I've cited several studies that place them anywhere from about a quarter all the way up to 71%. And it really depends on who's doing the asking, who's being asked, and how the questions are being asked. So I think generally the literature tends to say about a third of older adults are experiencing loneliness at any given point. I mentioned earlier there are absolute links between being socially isolated and lonely. But again, you can feel lonely even when you're surrounded by people. The adverse impact, and we'll delve into that a little bit a few slides down the way, really does have a more significant impact as we age. And then the whole issue of cognitive function, return to that one as well. So what are the risk factors? Being female, speculation around females being more at risk is that we have different, we're wired and socialized to have different expectations for our social relationships. So when they don't meet our expectations, there's an event that occurs. Prior history of experiencing loneliness, any current mental health diagnoses, some medications actually contribute. Being isolated certainly can put one at risk as well. Frailty, we'll talk about that one in a bit as well. And then living in a country or community with higher income inequalities. Turning now to looking at social isolation, what do we know about that? Well, we know it costs Medicare, by their estimation, about $7 billion in increased primary care visits, increased visits to the ED, and increased hospitalizations. So it has significant impacts is part of the takeaway from today. But what do we know specifically about social isolation? Well, we know it's absolutely linked to cognitive impairment. And think about what being around other people does. It's cognitively stimulating for us. Any age, any setting, you know, our brain is working harder. So we're isolated. There's a lack of using and stimulating the brain. Can be an early indicator of dementia risk. Also contributes to accelerated brain age. Prevalence really is highest in older Black adults and lowest for Hispanic older adults. And again, there's lots and lots of different studies out there, so I've just kind of picked a sampling of those. Looking at the risk factors, age. Age is absolutely a risk factor. As we get older, our worlds tend to get smaller. We experience losses of things that were formerly meaningful and engaging for us. So there's that. Having less than high school education and low income probably relates to access. Being male, having minimal to low social support, being a non-homeowner, which may also connect back to income, which connects to access. So if you kind of think about this as a bit of a cascading kind of effect. Being unmarried, unpartnered, that is a recurrent theme for both loneliness and social isolation. Cognition is there, number of chronic illnesses, which I'll talk a little bit more about that, prior history of depression, and then of course, poor cognition again comes up. Cognition comes up a lot, you know, in here. I looked specifically at this report, and I looked at Michigan. Michigan is ranked 30th as being at risk for older adults to be socially isolated. It's actually not as much at risk as Missouri, where we live. So there's that. But the color coding there probably has more significance for you all than it does for me, because the darkest blues are the ones with the counties with the highest risk. And so I'm sure you're more familiar with where those are and what the composition of those counties are. Certainly, you know, that's true. When I look at Missouri, I can tell. And it tends to be rural communities. I don't know if that is playing out in this. And if you want to look at other states, here's the link to the report. Okay, so what are the predictors living in a rural community? Because what happens in rural communities is young adults leave and families leave. And as the economic opportunities are not as great in rural communities, you start to see an exodus, leaving oftentimes older adults without the usual support system. Poor functional status in activities of daily living, instrumental activities of daily living, particularly for women. Here's this cognition issue again. Here's the unmarried, unpartnered issue again. Being female, again, lower income education. And then the subjective kind of causes, physical health, as well as these losses that I talked about. And I will just make a brief comment if anybody works in long-term care settings. Long-term care settings have a higher rate of loneliness, see, not social isolation. One study that I looked at that only looked at one facility, I have to say, found 100% of the residents of that facility reported that they were lonely, 75% of them severely lonely. So, you know, yes.
When you say females increased expressiveness, meaning that they actually state or declare that they are lonely?
Yes.
Okay.
Yes, and stay tuned. I have more to say about that in a few slides. Yes, when I talk about assessment, that this issue comes up. However, all those things are predictors, risks. The strongest ones are the four that are highlighted here on this slide. So having had a history of experiencing depression, living alone, not to say that living alone is a guarantee, absolutely not, but there is a 32% increased risk of mortality for people who live alone. So there are some issues related to living alone, but you can live alone and have a very active social support network and life. Feeling poorly understood by others. This one is, needless to say, challenging to measure and to sort of pin down, but it kind of comes back to the issues around personality characteristics, but just this general sense of not feeling like people get you. And then being a member of the LGBTQIA+ community, about 51% in the most recent study I saw, which just came out this year, by the way, report being lonely, but it does also kind of follow the other statistics I've shared in, it does increase with age. But all the other factors are very similar. I mentioned that I was going to circle back to this issue of cognitive function. Lots and lots and lots of research is being done looking at the connections to cognitive function, which I think is great because it also gives the evidence that we need to really get into assessment and intervention kinds of issues. So I'm not going to spend a lot of time on this because I really sort of already made these points, but you know, persistent loneliness, chronic loneliness that goes over years has been well accepted as a risk factor for dementia. However, interventions can turn that around to an extent in some cases, not guaranteed, of course. There was a very large longitudinal study that resulted in findings that said there's an increased risk of 1.26-fold increased risk for dementia, independent of the loneliness issue. Another very large study looked at it in terms of all-cause and vascular dementia. So these are all issues that we need to be aware of. And as I talk about what can we as professionals do, I'll talk about how to incorporate this into your practice. So looking also then at social isolation, we need to be asking those questions as well, because as you can see here from the 3 bullet points, and points I've already made, there's connections to cognitive function, and again, links to depression. And we also need to be thinking about and making sure we're talking to older adults about sleep. We have greatly underestimated, we, provider community, have greatly underestimated the impact of not great sleep. And so we know from the research now, we know that when someone's not getting adequate sleep, whatever that is for them, that it can impact their cognition, absolutely, and a whole host of other things. So here's a question for all of you to consider. I've made a bit of a doom and gloom, I'm sorry, case for the impact of loneliness and or social isolation, but in terms of its actual health danger, is it greater than cancer, cardiac disease, obesity, or substance abuse? So for those online, put in the chat box what your thoughts might be about that. And for those here in the room, who thinks it's worse than cancer? Okay, got a few. Cardiac disease. Yeah. Okay, obesity. Okay, a lot more on that one. And then substance abuse. Okay, all right, stay tuned. There's your answer in the bottom green circle. Loneliness is more dangerous than obesity. We know how dangerous obesity is. We hear that all the time. In every corner of the world and in our lives, we hear that. But did you ever think there was any possibility that loneliness is actually worse than obesity? That's one to kind of think about for a bit. Moving on to talk about, sort of this greater impact. So from the physical health perspective, chronic loneliness and or social isolation put you at increased risk for cardiovascular disease, no question, neurologic and immune disorders. It can co-occur with frailty and an increased risk for mortality. Alluded to that. But here's a new one. This is a fairly recent finding. Increased risk for type 2 diabetes. And we know how bad diabetes is. So mental and cognitive health things, I've really talked about it. I guess the one point I want to make about that middle column is that there is a 40% increased risk for dementia for people who experience chronic loneliness and social isolation. Healthcare utilization goes up. Oftentimes people will use the healthcare system as their social support and network. So there, as I've alluded to before, there tends to be increased emergency room visits, primary care provider visits, and hospital days. Institutionalization can come earlier or instead of, an alternative for people who are experiencing these things and have had this impact. So I really like this quote from Steve Cole, who says, loneliness acts as a fertilizer for other diseases. Biology of loneliness can accelerate the buildup of plaque in the arteries, help cancer cells grow and spread, and promote inflammation of the brain. That's a mouthful to think about the impact of this. So, this is a shift a bit from just thinking about loneliness and social isolation to thinking about social connection. And as Dr. Grodin mentioned, the Surgeon General has really honed in on social connection becoming a public health priority. And this diagram from Van Orten, who's done a lot of work in this area, really talks about how do we get to loneliness? What are the paths? So it's this idea of social connection impacting our biological, psychological, behavioral aspects of our lives, and then that having an impact on the health aspects of this. So think about it from the opposite perspective, the lack of social connection and how it impacts going forward. If you're socially connected, you still have processes happening biologically, psychologically, and behaviorally, but there's this added piece that's very preventable and treatable. This is one, if you've seen anything on social isolation and loneliness, you've seen this. It's out there everywhere. Lacking social connection is as dangerous as smoking up to 15 cigarettes a day. Again, a doom and gloom kind of thing to monitor. Holtmanstad has done a work in this area for a number of years, and I find this particular part of the work that she's done being very helpful. Her team followed people over 7 years and found increased risk for those lived alone, socially isolated, and were experiencing loneliness. But the image on the side of the screen kind of helps us think about in a little bit more depth how this moves through the process. So we experience loneliness, it inflames our brain. That makes us feel irritable, suspicious, negative, fearful, nothing positive, obviously. That then tells our brain to misread signals. That then propels us into thinking that people maybe are threats to us. Our reality becomes distorted and the cycle continues. So lessons learned. We've talked about COVID and the impact. We've talked also about people wanting to age in place. A colleague of Dr. Grodin's and mine, Philip Rosario, I think made this really profound statement where he talks about people often can end up aging in isolation. So what have we learned? And what are we continuing to learn? The research on impact from COVID is prolific and continues. We've learned that people were absolutely more lonely and more socially isolated, no argument there, but it was variable based on whether you had much control, whether you were able to adapt to using technology, for instance, to be able to stay connected. Canceled events were a way of life there for a while. And that did absolutely result in increased loneliness and social isolation. It hit hardest males, non-Hispanic, white, older adults, and those with higher education and wealth. This last one has to do with, again, access, and people with more wealth can have more access. So that's kind of what we learned from the social health perspective. Physical health, we learned that people who had cognitive impairment were more impacted for all the obvious reasons that we know. You know, they're used to routine, that familiar things, and particularly we know that there's this connection between being cognitively stimulated and our brain function. People with dementia experience less distressing decline when they lived with someone versus living alone. Again, not a surprise. Vaccinations helped a lot because it gave people comfort and confidence to go back out into the world. So they weren't as lonely or socially isolated. What do we need? Well, what's also come out of that period of time is we need more interventions. We need more evidence-based interventions specifically. That's what my colleague's going to talk with you about. But we also need to be very mindful about the interventions fitting the person. So say enough about that. And we need to be more age-friendly just across the board. So what can we all do? And this is the lead in kind of to what Max is going to be talking about. We need to make sure we're treating, from the healthcare providers here, we're treating anything that limits independence. Here's a laundry list of things you probably have not thought about in terms of loneliness, but certainly can. We need to make sure we're, assessing for diagnosing depression, cognitive deficits, getting people comprehensive geriatric assessments with to do that. Monitoring people's needs, incorporating the patient and the caregiver and family into the treatment plan. So it's a patient, person-centered kind of activity. Social prescribing, I'm going to not say anymore because Max is going to talk about that in a bit. And then looking at what are the root causes? How did this person end up being lonely, socially isolated? Raising your own awareness by being, doing things like you are here today. But we also have to assume some responsibility as health and social service providers that we need the community to be doing. This is not just the healthcare community's issue or the social service community issue. It takes a village. So we need to recognize loneliness comes and goes, fluctuates over time. There is stigma attached to this, and many people will not admit that they are experiencing either of these things because they fear the stigma that becomes attached to that. At the end of the day, we all have to remember that everyone has a right to self-determination. And again, back to my point that I just made, we need best practices in this area, and we're going to share with them. So here's our man looking out the window. Again, no right or wrong answer. I don't know if he's lonely, but just what are your thoughts now as you've looked at him? So I want to talk just real quickly about assessment. The takeaway from this is it's underassessed. And I'll tell you why and give you some suggestions. I think probably at this point, with 4,000 healthcare systems in the US recognized as age-friendly by the Institute for Healthcare Improvement, we all have heard, hopefully, about the age-friendly health system movement, the 4 M's, which is what matters: medication, mentation, and mobility. These are all things that we, no matter what our discipline is, should be incorporating into our assessment and care planning. Took it one step further and applied it to loneliness and social isolation. So from the what matters, what we want to make sure we're doing is asking people what those expectations are for their relationships and are they being met. We want to make sure the communication is clear and interactive. We want to look at the medications, and for those of you that are in the prescribing business or doing medication reconciliations, because there are medications that can create things that affects in older adults that would make them withdraw and become isolated and potentially lonely. Looking at treating co-occurring conditions, the mentation issues, made my point about making sure that we're assessing cognitive impairment and looking for treatable causes of cognitive impairment. And then certainly mobility. Someone who's experiencing frailness, they have more difficulty being mobile. Anyone who has sarcopenia, for instance, or muscle weakness is going to have limited mobility, and that isolates people. So looking at all of these things. Okay, assessment, 2 ways to assess it. There's standardized measures that go directly to loneliness. There are standardized measures that skirt around the issues. And then there's a single question way, more qualitative kind of way to ask. Here's what's interesting about this, and this gets back to the point about gender differences. Women are more likely to answer if you ask directly. Do you feel lonely? Do you experience loneliness? Women, according to Nicholson and Thorson, are more likely to say yes or no. Males, on the other hand, will be more forthcoming and better historians if you give them standardized tools, measures. No comment on that, just that's what the research showed. So here's some sample questions that I've collected through our travels, and about ways to sort of qualitatively, directly and indirectly come at it. The one that always, catches my attention when I think about this list is the third from the bottom. If you have good news or exciting news, who do you call first? I think what that will tell you, it'll tell you a lot about somebody, and can also be a conversation starter and open you up for other things. And Max can also kind of address this, but this is a great image that was in a publication that came out just last year. Kind of looking at the overlap, there's a lot of tools out there. There's many to choose from. And probably the gold standard, the most familiar to most people in this work, is the UCLA loneliness scale. I see heads nodding, so people have familiarity with that. But you can come at this again through social support, looking specifically at social isolation, or specifically at loneliness. And there's no right or wrong way to do this. The important thing is that you do it, that you're asking the questions. In the ideal world where you have infinite amounts of time to do all kinds of very thorough assessments, which I know everyone does, here are the kind of things you would want to be looking at, and here's some recommendations on tools that we recommend. I can certainly, have an offline conversation with folks if you want to know more about these specific tools. This is a tool that our colleague, Dr. John Morley, created. He liked creating scales and he liked using mnemonics. This has been validated and actually is a study has just been completed by not us at St. Louis University, but someone else looking at it to validate it for Chinese American older adults. So with that, I'll just real quickly, any questions, comments from online folks or here in the room before I turn it over to Max? Yes.
Will ask for a copy of your slides, will they be available?
Yes, we will send a PDF to Dr. Groden and she can share those with all of you. So thank you for asking that. Okay, yes.
How, Jennifer Blackwood from Physical Therapy, how often does social media come into the loneliness piece? Because folks be saying, I don't see people, but I got my network. And every time the network word was coming up, I was thinking, are we saying network like people here, or how much did that play into some of the data that you presented?
Great question. The research is all over the place on this. Social media is great. It was the saving grace during COVID for many people. Social media is terrible. It's causing people to withdraw from the world and have these distorted thoughts because of all the things that get said in social media. But at the end of the day, when you ask older adults what they want in-person contacts.
Yes, they do.
We know that anecdotally, but the research also shows that.
So is that also what Dr. Murthy put in his book? I haven't had the chance to read that book. I'm interested in it. Did he have also that same conclusion before the pandemic? Like connectiveness and
Yeah,
it
well,
needs to be face to face type of thing?
I think we all had that because that was the norm. So yes, I mean, I think, he was certainly advocating for being connected. The pandemic changed our views of what that means, to your point. But I think that for the current population of older adults, social media, technology for, Zooming and teaming and all of those things did not exist for the majority of their lives. So of course, the in-person is going to be what feels most comforting to people and what people are most used to. So there's a place for both, I think is my thought. And Max can talk about this, we've had some very successful virtual groups and have been running virtual groups through his clinic for 4 years, spring of 20. And so I think that there's a place for both. Moderation, probably, with technology, might be a good idea for us to all keep in mind. But older adults anecdotally tell us all the time, yes, in person. Yes.
Donna Case, occupational therapy. Cheryl and I are a part of a research team looking at digital technology and literacy. And I just spent yesterday transcribing a focus group. And one of the things that our senior center directors talked about was older adults being very cautious about using digital technology.
Yes.
Because, and we've heard this anecdotally in some of our surveys that we've done as well, because they have a difficult time differentiating between what is okay for me to click on and what my family and everybody else tells me to do. And so I'm wondering if that becomes part of the reasoning why, because if we meet in person, we have an easier time to
Right.
tell
Right.
if this is a valid person or not.
Those are excellent points. And there's so much, if anybody belongs to AARP, I joined years ago just to keep on top of what was going out. And AARP is a wonderful organization. At least once a week, there's join us virtually for a webinar on how to identify scams. So people are aware that that's an issue. It's being addressed in a variety of different ways and places, but I think that it also serves to heighten one's anxiety about that. I pause. Yes, so.
Katie Garvey, I'm an OT who works in community. And I had read an article in preparation for this symposium where they had talked about access, having resources in the community and the timing of accessing them, that people wait until in one study, they were talking about how they may be out there, but A, they may not be aware of them, or B, they wait till crisis hits.
Right, absolutely.
And then because of the lead time required, and I always tell people you have to, plan for the worst and hope for the best, but and I'm wondering if social isolation and loneliness is sort of, people have this foregone conclusion that this is just part of getting older.
Right.
This isn't something that, and I can seek help for, sort of.
If I'm willing to admit myself that I need the help. No, I think you're absolutely right, which is, you just provided, thank you, more evidence for my earlier point that we, as those who work with older adults and are related to older adults, live next to older adults, need to be much more proactive about this, because loneliness and social isolation are preventable. Some amount of it sort of is normal, but chronically is preventable. And I hope I've made the case that chronic experiences in these areas can be devastating and lethal. So and people are resilient. That's what a lot of the research is now showing, is people are resilient, and you can go I don't want to steal Max's points that he's going to make about the intervention that we'll talk about if I take the stand here, is you can turn loneliness around, and you can turn social isolation around easily. Yes, thank you. One more question and then I'll, no? Oh.
Sure.
Oh, in the chat, yes.
Nancy online said, are there examples of positive uses of technology to reduce social isolation for older adults?
Yes, Max will talk about the way we've adapted the intervention that he'll talk about. But I did read a study that looks specifically at who benefited the most from using technology during COVID specifically. It was people with disabilities and the LGBTQ community were the ones that experienced the most benefit from being and staying connected to other people. But yes, I think we all know Zoom helped. One great example from the St. Louis area, there was some federal COVID money that was available. It was given to the county library system, who bought, now 3,000-4,000 grandpads and distributed them basically to anyone, who met the criteria of being an older adult. And no evidence, formal evidence, but the anecdotal evidence coming back from people is it made all the difference in the world for them to be able to stay connected. So yes, there are many examples. Okay, with that, let me stop talking and you let Max talk. Thank you. We'll come back and can answer any other questions.
Right.
Yeah.
See, the easier part of going second is she answers all the good questions and a lot of the other content, so makes clearing the deck for talk about Circle of Friends. So it was interesting when we were talking about generational differences with loneliness and social isolation. Our summit had a speaker talking about youth and social media. And it was interesting because the entire audience thought that social media would heighten the risk of loneliness and isolation for Gen Z millennials. There was actually an inverse relationship. So actually there was a little bit more of a community that was built in the younger generations, which was interesting. So got us to thinking around really generational differences in how we term loneliness and social isolation, because what we think of it now is not going to be there, 20, 30, 50 years from now. It's going to evolve and it's going to be a lot different. So some interesting conversations that we can get to, especially on the panel there. So, all right. By the way, just as a disclaimer, we didn't put this in the disclosures, but I was told by a Michigan grad not to wear red and gray this time of year. So I took the note to heart on the Michigan rivalry. So, all right. So we'll just talk a little bit more about the levels of isolation and loneliness, and then we'll get into Circle of Friends. And Marla did a terrific job giving the backdrop and story around it. So when we're thinking of not just interacting one-to-one, but on a community level, what can we do around this topic? So we always like to look at, as we're, increasing education and training, how do we really have boots on the ground? How are we able to implement a lot of these services and resources into communities? And what do we have to do to address this? So as you can see, the increased develop, address, and evidence has really brought up in the research quite a bit. But I think, again, it always starts on the left-hand side that if you don't educate and train providers, community health workers, and those that are really in the know of senior housing in different settings, you're never going to get the ball rolling in the other three categories. So again, it's a pay it forward from today. You really have to give the education and urgency to others on how big of an issue that this is across the map. So then we look at, again, how do we intervene? And we'll talk about Circle of Friends as a evidence-based and tailored intervention around loneliness and social isolation. But you can see here on the inclusion and connection parts, we involve many disciplines. We've done this in our mobile van unit that we've rolled out at SLU. So we're not only assessing for loneliness using the alone scale or questions. We just had a site visit at one of our community partners in North St. Louis City, and PT, OT, and medicine asked some wonderful questions around strength and mobility, and as Marla mentioned, the 4 M's. So you have to integrate a lot of those pieces when you're looking at the loneliness areas. And then we crosswalk that with social work and MFT. What did we assess for? What did we look at on the mental health and community side? So that really formulates connections and resources that you're really formulating a nice comprehensive treatment plan for that. And I think with the connection part too, which we'll get in Circle of Friends, there's a lot of barriers and challenges when you want to connect older adults in the community, not only to groups, but to other resources. I know we mentioned stigma quite a bit and health literacy. It's even asking the appropriate questions. I know one gentleman, he was in our mobile van clinic, and we were addressing loneliness and different areas. He had type 2 diabetes, he was overweight, he had very poor nutritional and physical habits. And he said, well, my way to combat it, because I live alone and don't have many friends, is to go to the casino. And we said, well, that wasn't the top option we had exactly. That wasn't even in the top 10, but people go to desperate measures of finding connections and where they have to fit in order to get out of their individual isolation. So I think being able to ask really sound questions and open-ended questions, as Marla showed on that slide, is important. And we even like to ask strength-based solution-focused questions at the beginning. I think when you put a lot of people on the spot, we get the interventions and connecting them to resources. It's really important to say, when you've heard good news, who are some people that you talk to? When was a time that you felt when you were socially connected with others? How did that change your overall sense of well-being or confidence? And so you want to start with those primary questions. I think when you start from a negative deficit perspective, really shies away people to be able to answer those things. So in getting into Circle of Friends, just a broad overview of interventions. Obviously, with many of the goals to connect, provide social skills, social contact. And these, even as we mentioned, we've seen a big overlap and association between increased cognitive functioning and connection over time too. In our cognitive stimulation therapy groups, we've even seen where people who have have been able to reduce isolation quite a bit. But a lot of the interventions need to also include areas such as physical activity, again, any parts of cognitive stimulation, and really the facilitators, as we'll mention in Circle of Friends. And a lot of you, whether you have led groups before, have any of you led older adult groups? Anyone out there in any form? I should, some of you, okay. We can probably spend a whole hour on the strengths and challenges around that. But as far as really empowering people to be in a group dynamic, it's also important from facilitators and those referring to give them enough information on what the group is about, knowing that this is going to be meaningful in their overall health, what their outlook is going to be for it. So really, there has to be a lot of prep work that you're doing, and especially if you're a healthcare provider. I know there's in-person, virtual, OT, and social work, a big presence here. So again, many of you are going to encounter, patient-centered encounters or work in community health facilities. You're going to come across this a lot of what's going to match the resource to where the person's needs are at. So a lot of that conversation is going to be right up front. And then just around the interventions itself, and again, we'll go through social prescribing a little bit during the panel. But again, really a goal of that is to find connections from healthcare facilities or first point of contact, be able to get people connected in the community, and obviously electronic health records, that example that wasn't in there, but around healthcare navigators, health advisors. We've actually, when I've talked to people from the UK, and we'll discuss this later on, social prescribing has actually been a social prescriber. So there's actually positions and roles in the UK in their health system where they made this an actual hired position, where they're looking at ways to connect patients with their community, ways to navigate the healthcare system better. So that's really exciting. And we talked about a lot of the online connections and virtual means to do this. We certainly come across, again, a lot of the challenges that take place with technology and just a fear of pushing the wrong button or disclosure of information or what's going to be out there. And I think that's been much more of a contributor to the loneliness than I think they have an urge to want to do this a lot more, but we've seen that in our groups. And then certainly from the community-based perspective, ways that we can promote this more in the community. We'll mention one of the examples, there's an amazing nature type connection project globally called Recitas that our partners from University of Helsinki in Finland are part of. I believe it's a 7-city initiative across the globe, and we'll provide some information on that too. But we will get in specifically to Circle of Friends. And as Kaisu Pakala mentioned, it's not the activities or the leader itself, it's the peer support, group dynamics, and cohesion that makes the group sustainable over time. So this is going to be very different from most groups that you think about in your psychoeducational groups or your behavioral centered groups, where the facilitator is a little bit more the educator or the therapist or the provider. You really have to have a more flat hierarchy within the group. If you use a top-down approach in this, it's not going to work. So this really came actually, let me back up. How we went through this process at SLU, and I'm being very sarcastic here, was a rigorous academic process where Dr. John Morley had traveled across many parts of the globe and was in Helsinki and met with the team and came back and had a conversation with Marla and said, yes, during my travels, I found the Circle of Friends group out there. It's amazing. We got to do it. The end. And then Marla comes to me and I say, well, that's great. What's John going to be involved on and how are we going to do this? And she said, John just told us we got to do it. So here we are. So 4 years later, we have several groups that we have implemented there. And obviously we took the time to talk with the group over there and to really run through the model, but it's been incredibly rewarding. So COF really goes through a group rehabilitation model, which means that from the background of the framework, you want those who want to rehabilitate into society and back emerging to finding connections, almost kind of finding their youth or their former self of what they, wanted to create as their own community. Because what they saw in Finland and doing some of the early trials, even in community dwelling villages and remote rural areas, people are becoming incredibly isolated during retirement stage, older adult stage, can't find any of those meaningful activities that were taking place. So we'll show a few studies there of the impact, which are amazing, but really simply the aim is to alleviate and prevent loneliness overall. And the group of around 7 to 8 people meet once per week over a 3-month period of time. So it goes for 12 weeks. The calling card of this group really is after the 12 weeks, the facilitators want to encourage maintenance to take place after the group is finished. And not only the group sustains, but you have 2 members who are the champions who actually run the group after. So if the facilitators branch off and you have a few people that emerge as the leaders of the group. So again, it's a very community and patient agency centered model of alleviating loneliness, and with making new friends, feeling less lonely, trying to find more connections, and even inviting more activities and experiences that people can do. It really bursts them into the community and doing things a lot more. And we've seen that in many of our groups that have taken place. So again, it's very group oriented. And when we go through a lot of the activities, the disclaimer in all groups is that you don't want to make this so manualized that it's only you telling the group, here's what you do. So you give some options for that activity, but if there are common themes or things that people want to go back to, you work with it. So it's kind of a nice flipped model. And I think a lot of groups that are out there in research need to follow this because, you know, oftentimes as you see, we have so many of these prescribed, manualized, you know, follow it to a T to the a specific minute or even second of here's what we're going to be doing in the group. And sometimes we just get so locked in, we're not really hearing the voices of the people in the group themselves. This is some incredible research that was taking place from the Finnish group over time. And you can see numbers of a 97% survival rate. So to Marla's point, all these chronic condition risk factors, after years of participating, these people are sustaining. And even those in their 80s and early 90s have been taking part in the group for quite a while. Only a 2.5% dropout rate from their early clinical trials for many of the maintenance groups. And you can see in that second trial with 117 people, 95% reported no loneliness after they did follow-up more longitudinal tracking of outcomes over time. And anywhere between half to 2/3 were making new friends. Even close to half of the long-term multi-year groups were continuing to meet. So this is a huge buy-in that was taking place in Finland. And it's no surprise they're, you know, reported as one of the happiest countries in the world.
Yes.
So it's nice. They had a little bit of a head start in doing that, but still, you know, this obviously heightens their need for community and what they're doing. So obviously, some of the mechanisms on really why it worked. The input is very positive and a person-centered focus as far as people trying to connect and really share a lot of their vulnerabilities, narratives, and experiences. Anticipating, because there's always questions of people that have a history of, you know, mental health or depression or other issues. How do they bring that up normally in the group? We never want to put people on spot in a group format to be able to share or make it, you know, more psychotherapy. We always tell our facilitators to really stay away from that. So this is the group really giving one another the resources and engagement and support that they can work on. And we've also seen where the stimulation is increased in brain behavior and better neural pathways. There's a lot more research on the neurological side coming out on social isolation and neurological effects too. And, you know, the dropout rates, again, we've seen a lot of success of maintenance groups for Circle of Friends, even during the pandemic. When we had a group prior to the pandemic and went to phone, we were able to complete almost 12 sessions by just a phone group, and then they continued an extra 2 months. They knew each other quite a bit, so there was some camaraderie, but it still is amazing, and especially we saw that, you know, during 2020 and early 2021 of just how important the connection is through any types of means that they can connect on. And the long-term evidence, I would encourage all of you to read Andrew Jansen's 10-year follow-up study, which is incredible. That really shows you not only the sustainability, but a lot of the mechanisms if you're creating a group, and even if you're doing things in the community around social isolation that really impact over time. And they talked about the buy-in from the facilitators, but also really the need for the group champions who take over the group, that they're really invested over time and they're a really good fit for what needs to be done long-term. So again, it's been very effective. And when they stuck to the original protocol, you could see a lot of success that were happening. And again, it's just some of the general statistics. I think this is even getting closer to about 1,000 facilitators that are trained because they're doing more even this year and involving more people in the Receive Us project. Over 120,000 adults have participated or have been impacted in some way from this. So this is really becoming more of a global centered group. And even the settings on the right-hand side where this is being implemented, we just had a grant from St. Louis Senior Fund where we launched our first group in a primary care clinic. So that was not without challenges, I will say, but we got it launched. It was successful. We had a few follow-up visits and one where they met in our park and had lunch, and they were able to bring over some food, and they actually had some gratitude statements and narratives that they read to each other. So it was quite powerful as far as them meeting together after the group was done. But even with different populations and such, it's been really meaningful. the Association with Developmental Disability on Aging in St. Louis, one of our partners, has been able to incorporate this with a lot of their residents and have seen incredible success over time with this too. So if you are interested in forming a group, this is not the end all be all criteria, but something to consider. The age in which they recommend 65 and older, but we have had people as young as in their mid-50s be able to participate. The subjective feelings of loneliness, we have used the UCLA loneliness scale, alone scale, or other metrics for screening. If there is telehealth access that people need to work off their own laptop or tablet, they can do so. I will say for overcoming any fears of technology, we always use what's called a session zero. So before you start a group with this population, do a test run on Zoom, Teams, or whatever platform you use to not only test out the technology, but having a caregiver there or having someone that can incorporate it and be there. We've seen much better retention rate when we had a session zero compared to just launching into groups. So having that prep really helps even for homebound individuals. Hearing, vision, mobility, as well as cognition and any memory impairment, you definitely want to track. It's not, again, a full exclusion, but making sure that people, especially in person, are able to interact well enough within the group setting. So here's just an overview of the session components. And again, as we mentioned, the nice thing about Circle of Friends is you don't have to make this a 4-session, and we're done at 12. Here's some resources. Next group, we'll see you later. This is, we want to incorporate several of your interests and things into this group. And hopefully when we get into maintenance, be able to touch base on this or follow up to see what have you done in your community or outside of your home with any of these areas. So the art and activities, which groups have had a lot of fun doing, and our community partners have done things, not just attending cultural events or working on any arts and activities, but we do things virtually as well. We have a virtual tour of the Louvre in Paris, and they've had a lot of fun being able to tour through that and see it. Sometimes we go over time on that group quite a bit because they really want to get into it and talk and discuss it or go back to it. So, but if you're doing a lot of this in person, again, nature walks or meeting spaces, even something that simple helps. The exercise and health theme discussion, that's a little daunting for some people in thinking, gosh, I don't want to exercise. There's no way I want to do anything out there. But we talk about how people can get back into getting engaged more with their overall well-being. I know one group did a steps competition to see if the whole group could hit 1 million steps. I think it was a very high bar that they set, but I think they got fairly close actually. But they were calculating it, and it was a lot of fun, and there was an accountability. So I think even if they're not doing anything with swimming or dancing or yoga or meditation, just the fact that they're staying active and talking about topics is really important. And then finally, with the therapeutic writing, this was an area that we tweaked a little bit. When we talked with the Finnish group out there, they must like journaling a heck of a lot better than the US. Because when I was talking to a lot of our participants at the beginning, they said that this is like homework. I am not doing this. If you're grading me, I said, we're not grading, it's not homework, and this is all for you. So we tweaked that quite a bit. People brought in photos as reflections of their family history. We brought in a bunch in person of Hallmark blank cards. If you were to write a gratitude letter to a friend or a family member you wanted to revisit or get back to, what would that look like? So we did a lot of kind of one-off activities around there, and that was a lot more inviting than the participants were willing to do. So as we mentioned, again, with the activities and art discussion, a lot of this is also reminiscing on concerts, past sports events, museums, things that people did, and just the discussion and motivation to re-engage in this. So really, one of the interventions in Circle of Friends is not just the follow through on activities, it's the motivation level to get people inspired to get back, rehabilitate, to socialize in their community. So the conversation, making it uplifting and positive certainly is important. And again, some of the activities they can talk about, not that they all have to follow through with it. I know again, the nature walks, as we'll talk about a little bit, that's really, really helpful and beneficial. And based on if you have some, parks within 30, 45 minutes of here, or even some neat destinations and things that people can go to. I think all of you have plenty of options around here too, which would be really neat for older adults. That can be cool. And then again, with the writing, it's optional for people to write. They can also on virtual groups be able to show things, from their own personal history, family history. There's sometimes family heirlooms and things that were, neat cultural remembrances that were nice to hear about too. So, but we'll give you some tips as far as how to handle things virtually and make sure that everyone has a chance to provide some good input on that as well too. So I know for those of you who were on virtual or may be interested in doing virtual groups, there are some adjustments obviously you do have to make, not just with Circle of Friends, but with running any group online with older adults. So where you can do things in person on the left-hand side with arts, exercise, any therapeutic writing, bringing in guest speakers, bringing in, the tour guides or tour sites that you can show. If there's any videos of strength training or other activities that you can screen share with them, makes it really valuable. Also, because you can't see them, one-to-one in person, anything that they want to do in their home or residency of projects without calling it homework, but that they can be motivated to do is certainly helpful. So I know we all know obviously Zoom or Teams well enough, but facilitating is a whole different ballgame when you're trying to handle that. So see a lot of heads nodding right away in that one. So as far as some general takeaways that we have, not just from Circle of Friends, but as far as addressing loneliness and isolation in general, I always like the ecological model in a lot of respects. And truth in advertising as a systems therapist, as a MFT in background, really want to look at this from all 4 different levels here. So individually, how are we addressing the biopsychosocial and even spiritual needs of older adults as they try to connect and really finding more of a internal value as those age of how do they want meaning in the world with their family, with their social networks within their community. Family comes into play quite a bit. And when we've had a lot of services at SLU, whether in primary care in the mobile van and community clinics or having other meetings, how can caregivers and other families be involved? It's amazing when we assess families and they said after a 30-minute conversation, I had no idea so-and-so was this isolated. So even just the definition and the assumption of, I thought this was just normal for them, but how much they're reporting that they're struggling with, they're putting 2 and 2 together. So really important. Community is always important. Obviously, I'm preaching to everyone here who are current or future providers or those that will work in many areas of healthcare and community. Really, really important that we continue to screen for this. When we're talking with many of our physicians and doctors and healthcare providers, we tell them you can't go from 0 to depression, right? There is a middle ground here of loneliness that you have to assess for. And I think that's where a lot of the assessments get to. And that's oftentimes that gray area that providers miss. They'll just jump right into, let's code for mild depression, let's get them on a medication, let's get them started right away and do this. So really educating and training those in our community to assess for this is important. Also, those that work in housing units and housing authorities, we have another great partnership with St. Louis Housing Authority, who does wonderful work with their residents, and they developed nice pins and collages and quilts that they've made from their groups, which is really neat to see. And then finally, from a societal level, I think policymakers and organizations, timely topic certainly now, attention on a broader scale on what we need to do to address this within our healthcare system, and making sure there's measures to bring about the attention. The Surgeon General's warning, last year was certainly a wake-up call for everyone. It was actually one day before Marla and I gave a talk to a GWEP group nationally around this. So that was pretty good timing, but we have to think of this really on all levels if we want sustainable change. But, you know, all of you can and should make impacts at least one of these levels really going forward here. So just a little bit of promotion in our products, because I guess we can. For our Healthy Aging Clinic, one of our groups that we run is Circle of Friends out of there. We do run virtual groups, but we're also open for consultation whenever. So if any of you are interested in developing a group or have questions, we're more than happy to address that as needed. We also have cognitive stimulation therapy, caregiver education and support. So we have a lot of opportunities that we can share with people around that, and really expanding a lot of our services that we're doing over there. The Circle of Friends training guide, we can also send you a link as well to that. If the QR code doesn't work, we'll make sure to get you the link. But it's an incredible facilitator training guide that we developed, and huge part was to Marla's two social work students that developed a lot of this, which was really neat to see. So they not only developed the training guide, but were instrumental as one of the main facilitators to start Circle of Friends. So there's questions on the assessments, how to start a group, you know, elements of sustaining it over time, a lot of things that you can find within there. And just some recognitions out there. So obviously in 2019, obviously the rigorous story I told you about 5 years ago, with University of Helsinki, we want to thank them so much, obviously, for, you know, all of us being able to adapt it. The N4A and Resource Center for Engaged Older Adults, the Innovations Hub, they're doing some really incredible things over there, and just even on a national level, being able to house a lot of resources and get people involved in this topic is really impactful. We were listed for both Circle of Friends and cognitive stimulation therapy as an evidence-based program. And we always encourage different states that if you can try to work on getting an evidence-based program listed and approved within the state, does wonders for many things, from clinical, for applying for grants, for pitching it to administration. There's a lot of benefits that you can do on that. And obviously for National Council on Aging, for the approval of this, it's, you know, on a national level, then it's been really neat to see not only from state levels, but how this has been expanding. And we'll also say that I know GSA and other places that they're forming interest groups in other areas too. So if you're involved in that association and the conference is coming up, they have loneliness special interest groups that you can get on their listserv and get some more information about as well. Here's some of the resources that we'll share amongst the many. I know people really talk about what's another group out there that's helpful. That ARP one, the Connect to Effect, that's a really impactful one. It's more of a liaison to community resources at their national level, but I would check out that website because it's really impactful. And as mentioned with receipt tests, we'll go through that a little bit during the panel discussion, but we're really trying to bring in natural environments and local parks and resources to bring people together. We've been actually talking with a person in St. Louis, and he's owned a little bit of land around Cliff Cave, a park in St. Louis, and we're trying to get one of our groups over there in a maintenance group. So we're doing an iteration of it, so to speak. But again, check out that website because it's really impactful. So, and then I will just say, save the date for, we have a virtual conference from 9 to 4 on March 28th. Fromel Walsh is going to be giving a talk there. That's on resilience through grief and loss for caregivers. We are going to put a plug into that talk during the day. And we're looking to hopefully have a live family interview as well too. So not only have Froma there, but maybe an afternoon family where loneliness and isolation will come up quite a bit. And we didn't even scratch the surface on caregivers and care partners, how big of an area that is, because that's a huge, huge topic. And we've had a lot of conversations too of, okay, the patient's isolated and lonely, what about the caregiver and the care team? Well, when that starts to get affected, now you have a bigger systemic problem. So stay tuned, feel free to get on our list or for that, we have some sheets and handouts that we have for there. And as mentioned, the Center for Healthy Aging, if you have any questions, you can reach out to us certainly at any time about Circle of Friends, about this topic. There's a lot of research that's emerging, so we're learning on the fly, you know, as we go to with everyone. But again, it's such a big topic and so important, and that's why all of you are here. So, we're at the last slide, so I think we're good.
So it's 10:30 and we can either answer a few questions real quick while we're in the movement or our break is from 10:30 to 10:45. So do you want to answer any questions right now?
We have chat.
Yes, Bridget in chat says, I'm wondering how the interventions for loneliness work, social isolation, loneliness contribute to decline in health. But it looks like the people for this intervention need to be fairly healthy, mobile, and cognitively intact. Maybe this is to catch people early. They were wondering about that.
Yeah, so that's a good question, a complex one too, because I think there's gonna be no perfect criteria for getting people into the groups. Obviously, we've had some compromises in some of those areas for group members, but can still allow them in. I think with any group setting, you wanna make sure that the engagement and conversation, people are able to track through, you know, all of their sensory capabilities, certainly enough is there. You know, people have had other chronic health conditions that they've certainly been able to be included in the group. And actually, where they're talking about discussing, there's commonalities that the group mentions that can really help them there too. I think around the cognition and memory loss, where our cognitive stimulation therapy specifically hits that and targets that, we've had a few challenges where if people aren't able to track or repetitive too much of stories, or it feels like it's not really meaningful or doing enough, we usually have a conversation with them and their care partner outside of the group early on to figure that out, to kind of screen for that as well too. But I'd say as far as health conditions are concerned, especially when we get to those activities, we like to talk about it and where people are comfortable as well too, without getting too deep, or people who have past trauma or evoking things that are too difficult or sensitive. Okay, a lot. Okay. Second row first.
Oh, thank you. I was curious about the facilitators.
Mhm.
They're obviously you look to recruit them from the group membership, or do you go outside? And how long does the training usually take, and how's your retention?
Yeah, great questions. For the facilitators themselves, I mean, we've had a lot of student providers that have facilitated. I mean, the majority in our center but from MFT social work, we've had med students, we've had those from OT, PT, speech language. So I think, you know, obviously them going through the training, having some experience around aging, it doesn't have to be X number of clinical hours, but at least, you know, having a good basis for that. I think what's even more important we see in the groups are a lot of the interpersonal and specific mechanisms of the facilitator themselves. How they're intuitive, handling crisis, sensitive to needs, using very value-centered language for the older adults. So I think, you know, those types of dynamics make for great facilitators in that respect. The full training, it's we have a half-day training that we do, so a more extended one. We actually have a summer conference coming up where we're going to extend it into a full day. So we're hopefully going to be able to get a few simulation activities involved in that, but so we'll put a plug out for that soon. But yeah, that's where we really go in depth around the specific details of it, and then do some breakouts and examples on that too, so
And
there
so
was a
then-
third part that you had.
Well, those facilitators, so they are trained, most of them were students who are.
Well,
students.
most of them are students, but we have trained professionals and care partners, so Association for Aging with Developmental Disabilities, Voice Memory Care Home Solutions, our housing authority. And I mean, people around the country, we've been able to train different partners. And we've actually included a few other providers who wanted to give guest lectures or people to come in to help. So we've trained.
And then they've stuck with the groups, or then the group goes on its own? That was the part.
It depends on where the group wants to go. We just had our primary care group wanted to meet twice, but they said, we have a lot going on. So we want to kind of end it right here. But, another group was staying virtually up to 6 months, even a little bit after the pandemic. So it all just varies based on the group's needs and obviously what they have going on. When you have an in-person group, obviously if a caregiver, someone's taking them, their schedules have a big impact on that as well.
And are these paid, do you pay the facilitators? Are they volunteer? Do they get credit?
That depends.
Okay.
On year to year. So, some who maybe are on assistantships or, it's part of a practicum or for a clinical rotation. I mean, we can kind of fit in wherever is need be. But what we've done in our center is at least commit people on a yearly basis to be fully committed. Because if you're in a maintenance stage and, you can't just say, well, my practicum's done. So, if you all want to continue, sorry, see you later. You have to be able to continue that over time. So we have kind of yearly agreements with our facilitators that we've committed to. So.
Okay, thank you.
Our partner sites, AADD that Max talked about, that's become part of the case manager's role.
Oh, okay.
Housing Authority has had grant money, external grant money, and they have been able to offer stipends to facilitators. So it just, whatever
depends,
an organization has and what they can mobilize.
And then this is a one and done, or do you have follow-up as far as the facilitators go?
So the facilitators, and in the training we get into this more, the facilitators meet in between every session. And so they keep it, their own diary, just some notes, but then they check in. And then usually if there's a new facilitator or someone's in there, they'll have discussions, hand off. Usually one of the facilitators is handling the group dynamics, the other's kind of taking the field notes, so to speak, and handling that together. But they can switch off. It's really important you have two. And I can speak on that direct request because I have the worst case example myself, that I flew solo on one group and two people are getting in an argument over a topic. One had to go to the bathroom and then one was sobbing.
Yeah.
And I thought, I myself want to run out of the room. So, and thank you, student, for 10 minutes canceling, but so you always have to have really at least two deck, and being able to really interact with them in between sessions is really important.
Thank you.
Yeah.
I'm sorry, you talked about earlier about this idea that when providers are asking that it's often not the in-between time. And I know that just for my mother who has dementia and is older, and I take her to her doctors, they always ask about cognition and they ask about depression. Is there an idea or a plan to focus, like to get that so that Medicare is saying to geriatric professionals, hey, we want you to ask these questions as well?
I can speak, I mean, I know like on the Medicare annual wellness visit, there's a subset now where if the geriatrician or physician doesn't catch that right away, but which they should, we normally have behavioral health oftentimes to come in and help answer those. I know we've integrated also in our rapid geriatric assessment, other tools at SLU, where in the geriatric side, probably a little bit more than family medicine, is where they'll ask a little bit more specific behavioral, community and social type questions integrated in the visit themselves, which I know CMS likes quite a bit. I mean, any data that they can collect is better too.
So CMS has just instituted adding age-friendly health system concept framework to their repertoire. And I think that very indirectly gets to that, because from an age-friendly health perspective, remember that graphic, you have to ask what matters.
Yeah.
That's where you can get at the issues, as well as mentation.
Well, I'm gonna take this, I take my mother for her physical in December, and we will have a conversation with her.
Good.
Her,
Good,
her internist who's a geriatric practitioner.
Excellent.
wonderful. Oh, we got a few more. We'll go front then back.
I had a question on how you manage transportation when you do these outings. Do you usually do that as a group? Is everyone responsible for figuring out their own transportation?
I knew that was gonna be one of the last ones. I knew it. No, that's an awesome question. And it's so big. And we actually, Thomas Cujo, who did a talk for us when laying out, and then we had someone from the Missouri State actually said kind of 3 huge barriers for getting access around loneliness, resources, and transportation came up right away there. When not writing things into grants, and even that can be oftentimes difficult. We have, a few times with rideshare companies, and I know not just with this, but across SLU, we've tried to, partner with a few places within the city, to help transport people over. And obviously us at a university clinic and center, probably similar to many at U of M. There are some challenges based on where people live. I think the biggest thing is making sure you schedule with the care partners or caregivers, times that are accessible to get over there and fit within their schedule. We normally do our groups no earlier than 10 a.m. and no later than 3 o'clock. So, within that time range, it's where people obviously are, I guess, the perkiest. In as far as being in the group, but also where the caregivers are able to, really be accessible, and, even if they're able to take off their lunch hour and help. But yeah, I'd say really writing into your funding, if you do any of that, make sure that you budget out for any, senior city transportation services that you can. We learned that the hard way on a few of them, just of you pass grants and you kind of Monday morning quarterback thinking, gosh, we didn't use all that, it could have been spent to it. So one in the back, or the last one.
2 questions.
You, okay.
Yes, simple, yes.
Okay.
And one in the content of the session that we our senior center provided the art or physical activity in the community.
Yeah.
So my question is, do you provide the session you provided from your group, or do you collaborate with community agencies?
Oh, as far as recruiting and
Recruitment event you did.
yeah, great question. Yeah, the recruitment we get from a lot of different sources. We partner with many of our geriatric and primary care clinics to get referrals for people into the groups. We've also partnered with many of our nonprofit agencies and community centers. So that's been a really good source of referrals too. And we've educated and given some talks to our physicians where if they have conversations with caregivers or patients, they can promote this and talk about it. I think it always starts though with having loneliness on their radar to begin with. And when that prompts in their mind, they think, oh, we have a group at SLU that we can refer to. So the recruitment areas are good, but I think if people aren't aware on the urgency and need for it, and some of the rest, they're not as likely to refer in the first place.
Second question. So I like to see the characteristic of participant. You are in the medical school, so the characteristic of participant could be the patient of your medical school, or it's more likely to diverse across the regions.
Okay, well, I can speak as far as our groups in St. Louis. Majority of the people who have attended in person are within about 20 miles of St. Louis City. So we have a little bit more of a diverse group, which is good because for obviously conversation and for access, it works well. Yeah, the average age within the group, early to mid 70s was probably the average age across our group members that attended, but race, ethnicity, gender, socioeconomic status, there was a big spread within our group. Now, those in more of the rural areas in Missouri, you may find less diversity for sure in those groups. But I think when bringing people in from virtual means, I think even the rural areas have been really beneficial when they can't find a meaningful group. Those as far out as 60 to 90 miles outside of St. Louis, we've been able to bring them in. So I think you find a pretty big disparity as far as the group dynamics are concerned in a lot of our on-campus groups versus some of more remote groups. Mm-hmm. Okay, do I have to cut myself off?
Yeah.
Probably, yeah.
We will definitely be back in 15 minutes and we can handle more questions then. Why don't we take a break from 10:45 till 11 and we'll come back and we have a panel and a few other speakers. So there's more food and drinks. Please enjoy.
Yeah. Good deal. Got so many good deal. Right, so
The person.
birthday, I looked at
Yes, like you be here. And she's got the Spanish. I was glad to hear it's in St. Louis.
Yeah, we're looking at full circle for the community.
It's a certain.
We only market it. The first response just say.
today. I'm gonna kick off with Hagerman Center. Yes, Anna to come and speak a little bit about Slayton Solutions. And the reason is that thinking about creative ways to address social isolation and loneliness. The Center on Aging has a Center on Aging challenge connected to Slayton Solutions. And I wanted Anna to share with you. And then after Anna, we're going to turn it over to our panel and our guest speakers. But Anna, say a little bit.
Hi everyone, so my name is Anna Church. I'm program manager at the Hagerman Center. We're located in the School of Management. We serve the whole campus through our competition and various programs. Our mission is really just to start spreading initial interest in entrepreneurship and innovation, whether it be here on campus or we also work with local high schools as well. We have 5 different programs. It's the Faculty Innovation Awards, the Summer Entrepreneurship Institute, Zane Solutions, a interdisciplinary speaker series, and then student scholarships as well. So through this collaboration, we've been able to have a sub-competition for our Zane Solutions competition, which is really just a problem-solving competition. It's really low barrier to entry, pretty simple to do. Many students do it across campus in classes for extra credit assignments, different things like that. So we have a sub-competition that will run until December 6th. That will be centered around aging topics. So if you want to learn more about that, you can contact Dr. Groden or reach out to myself. Our email is hagermancenter@umich.edu if you're interested in any programs, and we have a table outside as well. So feel free to come chat with us after and let us know if you have questions.
Thanks for your time. So this next half, we're going to be talking to 2 panelists. Patty Kearns, who is the Director of Eligibility and Benefits at VAAA. And for those of you who may not know what VAAA stands for, it's Valley Area Agency on Aging. Did I get that right, Patty? Yeah. And Patty's been involved in aging services for over 17 years. She is an incredible resource to this community. Anybody has any questions, call Patty. That's what I do. Patty's spoken to a number of my social work classes and was, godsend for all things possible in this community here. And Katie Garvey is an occupational therapist, certified independent trainer and coach, and she serves on the Michigan Dementia Coalition and volunteers with the National Council of Dementia Minds as a facilitator and is a community resource for establishing network memory cafes in Southeast Michigan, which I look forward to hearing a lot more about. And we asked Patty and Katie to be a part of a panel to hear what's happening in the community and what can we learn from what's happening, what they're doing, think about how we can combine those efforts with the work that we're learning about from Marla and Max, and also want to hear from you. So those who are here virtually, those who are here in person in the audience, please jump in the conversation. I'm gonna over here with you guys, over here. So the first question that I'm asking to you guys is, what social programs or social prescribing currently exists at your community agency, specifically aimed at addressing loneliness and or social isolation? And seeing that word social prescribing, it's reminded me that we want to make sure we spend some time this latter half talking about social prescribing. Okay, so who wants to go first?
I can go first.
Okay.
I'm not usually too shy, so it's not a problem. Our organization is a nonprofit organization that serves Genesee, Shiawassee, and Lapeer counties. Our focus is seniors. We have quite a few programs aimed at social isolation and loneliness. The positive point of COVID would be it brought awareness. If you've been in the field, this has been an issue for decades. So I'd say the one thing COVID did bring is made people aware of, gosh, no one visits my neighbor next door. So we've developed a lot of programs prior to COVID. We do some telephonic wellness programs where it's just, we find that people engage in that because it's very non-invasive. They don't have to do a lot but answer the phone. They call, they do a wellness check daily. And if you don't answer the phone and you did not let us know that you weren't going to be home, then there's an emergency protocol that goes into place to make sure that you are safe and that we have had incidents where we found people that have had strokes or falls. And the safety wellness check was what found them and was able to save their lives. The other program that I run that really, people don't think of it as a social program, but it's a home delivered meals. And most of our seniors, we have over 700 seniors that receive meals in Genesee County daily. Sometimes the only interaction they get is with their driver dropping their food off. So a lot of people really count on that engagement as far as that goes with just having touch. They talked about in person. Telephonic is great to a point. I'm an in-person type of person, and our seniors, they want the touch. They want that one-on-one engagement. That's what really motivates them more. I think you'll see a shift with the boomer generation coming along, that their needs are quite different than what our older generation was, but it'll still be there for sure. And then we have a lot of evidence-based programs. We have a big program that stem from the Flint Senior, the water crisis. We have a program called Flint Senior Lives Matter. It's been 10 years. Sad to say, it's been 10 years that we still have this program, and it's addressing isolation, loneliness, and depression from our seniors impacted by the water crisis and then by COVID right after that. So they kind of got the double whammy here in Genesee County, and we're doing a lot of art therapy, and that's been really, really productive, really good to see the results from that. So that's a few of the ones we have.
Okay, hi, I'm an import. I'm actually in Washtenaw County. But I am doing community-based practice. I'm not delivering therapy services and billing insurance. I'm running a program called Ease the Day, which is a caregiver respite support program that we just embarked on in March of 2023. And it's been hugely successful, but this Chelsea Senior Center is a very, very, I really, it's a gem. Chelsea as a town is fairly rural. It's west of Ann Arbor, and very close to the Jackson County and Livingston County border. And the town itself has 5,500 citizens in its population, but we have 1,200 members of the senior center. That's because we draw from all over the rural areas. And we just won a senior millage in Washtenaw County, which will raise $11 million supposedly in the first year. We don't know who's going to get the money and when. Of course, you never do with politics, but we're hoping some comes our way. But the senior center came up with a strategic plan in 2021 after COVID, and it's extended it out to run through 2025. But the number one pillar for priorities was to reduce isolation in area seniors because it became quite apparent in COVID how much of it was going on. So they're doing that by identifying and reducing barriers, expanding programs to engage people, increasing communication outreach to non-members. The ROAM program, which is the Rural Transportation Program, kind of understanding its usage, identifying barriers and expanding its ridership. And also programs for isolated care partners and caregivers, which is where East Day came about. So they looked at technology because I think it was identified as a barrier for some of the folks, especially rural dogs. And they had a grandpads program that they ran. And it was small, but very effective. And people were quite happy with their ability to participate. The other thing is we have quite a few retired IT professionals. So they have drop-in hours every week, at least once or twice a week, where people can come with any IT or technology related questions. And it's so interesting because that conversation leads to other conversations and people will get referred to the front office for something else that came to our attention because of the technology challenge they had. I didn't have it, it's in my folder, but I brought one of our newsletters. We offer 250 programs a month at the center. A lot and centered on all different kinds of things. They have enhanced fitness classes as far as sort of evidence-based things. That's through the United Kidney Foundation. And as far as caregiver support is concerned, we now have 3 support groups. a grief and loss, a chat to heal, and a moment for me. They happen on different days at different times to try to be able to encourage people to come. And one of them is during Ease the Day respite care hours so that they can have their loved one be engaged while they're getting the help they need. We have a Connections Memory Cafe. And ours was modeled after one that happened in Saline, which is hosted by my faith community. And I helped kick that one off the ground. That has been so successful. We had 5 at our first Memory Cafe. They have over 60 people in attendance twice monthly. They've had to move to the Unitarian Church because we've exceeded our capacity. And then Ease the Day. And Ease the Day is funded by the Ralph C. Wilson Foundation. And we offer at least 2 days a week of respite. People are dropped off at 9:30, can be picked up at 2. The senior nutrition program, we have lunch together communally. And what I loved about it and why I wanted to hop on board is because it's very integrated. So it's just another program at the senior center that people can participate in. And it, great feedback from, they are using, I'll talk about that later. Anyway, and then they also have done outreach to non-members. So they really see themselves as a resource for all community dwelling seniors. So they got some ARPA funds, which they've used to buy lock boxes for homes so that if there's a medical emergency, people can gain access through emergency services, reflective street signs, emergency kits. They also sponsor a senior expo in the spring that brings all kinds of community resources together at the senior center, and they offer a wellness clinic. So they have programming that has to do with wellness and health, but also get flu, COVID shots, and other services.
Are there a lot of other senior centers nearby you?
So
Just
interesting
curious.
because the funding is so cattywampus as far as how things get funded. And we are a trusted community resource. And so unfortunately, there's a senior center in Dexter, which isn't far away, but that's kind of undergone a huge change. And so it's kind of unhoused right now. That's going to change, but right now they're in flux. And someone called our senior center and they got a hold of another senior center and were told that the person manning the phones was not hospitable and not helpful. And I thought, oh, gives us all that name.
To tourism.
Yeah.
I can speak because I live in a rural community in Washtenaw County. We have no services for older adults. We have
Okay.
no transportation. If you are in the school district that is the nearest little town, which is in another county, you can participate in the senior center. So it's not, the lovely thing to me about Genesee County is that everybody, you can go wherever you want. It's a millage. So maybe with our new millage that just passed on Tuesday, we'll see some of that, but it really depends on where you live.
And speaking of transportation, that's the other thing. That was a major barrier, but we, through a generous donation, have what's called the Ann van because the donor was named Ann. I think it was a legacy gift. And that van is available. And there's also a new program for Washtenaw County residents. That's countywide, but that program is available for people who need a medical appointment. And so the general transportation, that the driver that goes with them will sit and wait and bring them back and forth. And then we also, with the WAVE transportation in Washtenaw County, it's Chelsea and Dexter's school district but they will take you anywhere. You can schedule the ride. And we have participants in the Ease the Day program who use that service. And we have grant funding that gives people $40 worth of vouchers to take their transportation. It's great.
So I'm thinking about some of the questions that Dr. Berg-Weger and Dr. Zubatsky asked about assessment. And I'm curious, at each of your sites, how are you assessing for loneliness and or social isolation?
Well, we do for some of our programs, like for the KISS program and our art therapy, we're doing a lot of pre and post tests. So we'll do a pre-survey before they get enrolled to see if we've made an impact. We do a lot of that type of things. With our assessment with meals, we ask them more direct questions as far as isolation and loneliness. Do they eat alone all the time? I really like the question. I'm gonna be using that just so you know, as far as who would you call? Because you don't know. That's the thing about telephonic is you only know what they're willing to tell you. You don't have a window into their home. That's one of the things that VAAA prides themselves on is we're boots on the ground. We go to where the senior is and I'm a big person, an environment person. I just believe that, you could have the willingness and want to do something, but your environment could be set up for you to not be successful with that, depending on a million different factors. But, so yeah, that's one of the.
Okay, we do not have, I job share the coordinator role with a woman who has a master's in nursing, and I'm an OT, but we are a psychosocial model and we don't do a whole lot of formal assessments or anything within the program. However, I posed these questions at a staff meeting, and one of the things they talked about is that when you talk to members, and we have somebody who's involved in marketing, and she does these highlights, almost 100% of them give feedback. They speak to the center, helping them make friends, feel a part of something, and feeling less lonely. So they were lonely. We didn't know that they were lonely, but that's one of the motivating factors for them to come and engage in the senior center. And we at the Ease the Day program are using the Caregiver Intensity Index, which was formulated by Archangels, which is an organization out of Texas. And so we do a baseline 3-month, 6-month survey. It's a 25 question survey. And 100% of our participants in our program said that they feel less isolated because of their engagement in this respite care program. And to speak, as you talked about, the caregivers feel as isolated as their person they're caring for because it's a 24/7 job. And our caregivers run the gamut from siblings, friends, children, adult children. And our program is not specifically just for people with dementia. It's anyone 55 or older who has a chronic health condition. It just so happens that 100% of our participants at this point have a dementia diagnosis. They're at various stages, but it speaks to those are the people that are really seeking it out and recognize the need to get some respite.
I got you said one point.
Absolutely.
All the assessments that we talked about that are quantitative and have scores, I can give just one quick example. In our geriatric assessment clinic, we had a behavioral health student who gave the Love and Social Network scale. 6 questions on friends and family. How many connections do you have? And that the person kept answering 3 for all 6 items. And well, this is bizarre. So the student was very proactive and good and said, I'm just curious, you have 3 for all of these as far as friends and family. Who is it? And the patient, she responded and said, well, it's you, my doctor, and the cab driver.
Oh.
So that's just a good example of where you don't know how isolated individuals are going to respond and who's considered in their community or networks. I always encourage ask an open-ended question based on the numbers you have, because what you assume it may not be the right answer from what they're thinking.
So I'm curious, are there programs that you tried in the past that you're no longer offering? And what are the reasons why? What can we learn from that?
Everybody look at me. Well, I mean,
It's gonna be the first to fess up.
yeah, I'm trying to think of, one program that we tried and we were starting it right before COVID. It was called the BBB, Boxes, Bags, and Buddies. And it was a lunch program where a volunteer was gonna go into the home of the senior and actually create lunch with them and have lunch with them and, cook it together and then have socialization. And of course, COVID hit. And we weren't allowed to go into any homes or see any people, so that program went away. And not really that it wasn't successful, it was the timing of the pandemic and everything. Most of our evidence-based programs have all stayed. Grant funders really like evidence-based programs. They want the data, so anything that you set out on an endeavor for, think of how you can track that data and show that you're making an impact in whatever it is that you're trying to accomplish.
Well, I've been at the center since March of last year, and so the legacy, there was a program that sort of COVID inspired to call like a wellness check, and that kind of faded because I think it was a response to the immediate, and they suspended services, and so it was a sort of a crisis response. But it was difficult to recruit volunteers, and it was and I think it sort of lacked what's the word I'm looking for, like traction, because once things opened up again, that was like people wanted face-to-face contact to speak up, those who could. But I will say that we Chelsea is small enough and intimate enough that we do proactively check up on people. We'll do it informally. Just someone on staff will say, I haven't seen so-and-so in the last 2 weeks. They've signed up for meals, but they haven't been here. Could somebody reach out? And sure enough, we do. And there's a reason behind it, but just people are very conscious of who they haven't seen, recently. But that also the problem is those who we don't see anytime and are out there, so. Yeah.
But that's a nice sense of community that you have there.
Hi, we have a question from chat. Can someone address stubbornness in older adults and how to assist with handling this when there's something the older adult could benefit from? Examples, therapy, circle of friends, group, living with a family member.
Yeah, I could speak to that. We get it all the time.
Yep, every day.
So I don't think that caregivers are aware of the deep-rooted effect that they can have on the person that they're caring for. So what you have to look at it from their perspective, and it has a lot to do with autonomy, which we hold in such high value in our society. So it's just been being chipped away at for the older adult in particular. And so we've had lots of people who the caregiver, especially if they're male caregivers, reaching out for help somehow is a reflection on their poor caregiving skills. Like for better or for worse, especially if they're a married couple, like for better or for worse in sickness or health, this is my job and I'm fine. I'm doing this, everything's good, right? Well, in fact, they are suffering under the weight of all of that stress, and the dynamic between them has become so enmeshed that now we're at a point where they can't separate. Like there's so much anxiety on both sides. I've had caregivers drop their loved one off and say, well, now what am I supposed to do? Just like, yeah, I've lost the rest of the identity. And of course, social circles are changing. More people are infirmed. So the stubbornness piece, one of the things I say to the care partners are, make it about you, not about them. I worry about you. And I think that I'd like you to have some new friends, and I'd like you to engage. And you're really doing me a favor because there's some stuff I have to take care of that is so boring. You don't need to come with me, right? And you have to give it time, and you have to remain positive about this being a good thing. I've had people whose caregivers are so stressed out, and especially folks who are living with brain changes associated with dementia, they become very emotionally astute because the rest of their senses are really changing, but they can read a room very effectively because it's a survival mechanism for them. So the caregiver, when they become stressed out about something, they're looking to the caregiver to inform their response.
So we take a lot of calls. One of my departments is the Information and Assistance Department. We take about 55,000 calls a year. We do a lot of referrals and a lot of intake. And as much as people want help, they're very reluctant to accept help. And it often takes a lot for a person to make a call and actually ask for help. So whoever, like you said, your person on the phone wasn't very welcoming. That's not the message any agency would want to send, because the first thing you have to do on the phone is try to build some rapport and some trust with that senior. And I will admit, it's almost like sales. We have to bargain. I plead, I bargain, I let everyone know that you can stop any service at any time. You can withdraw from any program at any time, but I really encourage them to just try it. And I'll use that technique for me. How about you try it? This is your 5th time calling in the last 2 weeks. Here's some options for you. So it is a little bit of bartering. If you know family and you have family contacts, that you can have them try to intervene, but it is very difficult when the senior has their mind made up on something, that you're gonna persuade them otherwise. So it's really, if you can kind of shift it to, it would be great for your family if you tried this, or, different aspects. People are funny about letting individuals in their home, but I find that most of the time, 90% of the time, once they do that and they build that relationship, then they're like, how did I even manage without this? But it really takes pushing hard. If we just let everyone say no and walk away, we wouldn't have half the people on our programs. We really do have to push that.
And I would say, if you're getting into a confrontational situation where it's like, oh, but this would be so great. No, I don't want to. Then step away.
Yes.
Yeah. Give space. Maybe follow up with a phone call.
Yeah.
Or try another angle. Someone who knows someone. I just had an incident where there's a woman who was coming. She was having a great time while she was with us, but she was really resistant to her husband. And so he said, okay, well, she's not going to come. Well, one of my volunteers who knows them went up to her at lunch the other day and was just saying, come on. And so she said, yeah, I'll come back, but I'm going to come on the day that she's there. I was like, okay, that's fine. That's fine. Yeah.
Doing home care for 10 years, I had instances where caregivers ended up dying or had a very serious illness. And that was one of the things that, because exactly what you all said, that's exactly what addressed and sometimes it was more often males, but sometimes females as well. And being able to share with them, hey, you can't take care of them if you don't take care of yourself, and kind of reframing that, looking at, because sometimes I promised before God or whatever, I would take care of my partner, my spouse, whatever. But to help them understand that you can be taking care of them by providing something away from you, because if something happens to you, their whole life falls apart. So giving them, opening for the individual, the older adult that you're caring for, giving them those other avenues will, and I found that to be successful.
And I think with family members, just giving them, letting them know that they could get a little break, and, someone else can step in and help out with that.
Yeah.
And people are often, I don't know why, and maybe you guys have some statistical data, but people with cognition issues often are very resistant to family members. But they are easily persuaded by someone they just met. I don't know why that is, but they're very resistant when it's their own family trying to get them to motivate them to, whether it's take a bath or eat dinner or your medications.
Because they don't want them telling them what to do. And, going from spouse relationship to caregiver relationship is a big leap. Both parties don't feel really comfortable with it. And so I work with a Positive Approach to Care group, and Tifa Snow is one of my mentors. And the idea is like, know your agenda, but don't show your agenda. And I used to get it all the time when I worked in residential care. The daughter would come and say, I've been trying to get him to do that for forever.
Yeah.
How did you make it happen? I said, well, I'm not his daughter. I'm not his wife. And so I meet him where he is. I don't know him, I know him in this moment in time, and that's what I'm addressing. Sometimes all that history can be a burden, you know?
Oh, yeah. My mother, I changed your diaper, so I don't need to listen to you.
Yeah.
In her dementia. I mean, that's my interpretation. I think that is often happens.
Do you have any comments on the question before we move on to the next one?
Yeah, I agree with, I mean, the only other thing I was gonna say is oftentimes the stubbornness can get confused with vulnerability.
Yes.
And so I think where, the blame, I guess, you know, society has, but yeah, are the caregivers really, you know, doing enough, and the caregivers feeling guilty, or even the person themselves? I mean, it's a vulnerable role in a situation of, am I not doing enough, or I have to meet all these things in my grasp because I'm gonna fail if I don't. And so I think, to all your points, I think providers kind of, we have more time to kind of meet patients where they're at. Caregivers, it's so time sensitive and action oriented. I have to get this done. So, you know, where it worked with that patient, it's, you know, you meet in their contemplation stage of doing something, but small steps, it works, so.
I think the only thing I would add is to be able to normalize, you know, what people are feeling, because thinking back to the stigma that often comes if I admit this, if I accept help, if you can try to normalize the experience. Oh, there isn't necessarily something wrong with me that can be addressed. In terms of, I was thinking as I was listening, our community partners did some really interesting recruitment kind of strategies. They had did two things, which sound kind of contrary. They did one-on-one contacts with residents in the buildings, and said, you know, we've got this group, love for you to be involved. And we were clear about what the intent was. The other one is they used other residents to do the promotion of some of the services and a Circle of Friends group. So.
And we use seniors for our telephonic wellness program. It's kind of a win-win. We have a retired senior volunteer program. So the seniors are active and want to volunteer, and they're helping out seniors that need help. So it actually, that program kind of started from a AmeriCorps giving seniors jobs. And then we found that it was actually very beneficial for the clients receiving the services as well. So it was a win-win for everyone.
Okay, so a few more questions here before we turn over to more about social prescribing. We talked about strategies for reimbursement. And I want to see if any of the programs that you mentioned, are they any evidence-based programs which are eligible for reimbursement?
So we have, we get reimbursement on our Silver Sneakers program, which is an evidence-based program, just activity-based, getting the seniors out and about. And then we also do medical nutrition therapy that we are allowed to bill Medicare for. So people with, diabetes is a very good one. We have a lot of diabetics will go out. We have a registered dietitian, and they'll do some nutrition therapy and, just meal planning and things like that. With our seniors, I think healthy nutrition becomes a big issue because access. And what they have access to is usually higher sodium, not so much healthy, or they can't, cooking is different in your senior days as it is in your younger days. Cooking as a senior could just be making a sandwich for yourself. It doesn't mean you cooked, the 5-course family meal. So often convenience weighs out over healthy nutrition, and that affects all aspects of their life.
Well, the whole reimbursement, we get underwritten, and obviously grant writers like the evidence-based. I would, the enhanced fitness, I think, has a long history and is really well established. And we have some programming that is underwritten by the University of Michigan in Ann Arbor. And it is to address specific, I think, social determinants of health. And so their funding is based on whatever research that is currently being championed by the university. Ann Arbor Community Foundation and Five Healthy Towns Foundation are also underwriting a lot of our initiatives. But the idea of it, we are stewards of resources that are given to spend in a particular way because so often in some of the scenarios for reimbursement, the administrative piece of it becomes so burdensome. It requires a whole other full-time employee, which then makes the program more expensive, which means you need to get more funding, and it's this vicious circle.
One of the things that we learned early on in the work around Circle of Friends was that state level departments, in our case, it's called Health and Senior Services in Missouri. It has different names in different states, but is the conduit for funding that trickles down to the area agencies on aging. I assume that's kind of what you've been talking about. And we were encouraged to initially to apply to the National Council on Aging to get evidence-based approval so that any AAA in the country could draw down on their funds. Well, the NCOA application process was paused several years ago. I check monthly, it is yet to reopen. So that was a deterrent. Then looked to the state level. So when Max talked about the fact that we were approved in 22, we were able to get Circle of Friends added to the Missouri state list. So now as we're talking to other, as we give talks around the country or have people attend our training, we encourage them to go to their whatever state entity that is, and we've helped people, with applications. Which actually in Missouri, the application was amazingly easy.
Wow, never heard that.
Yeah.
But it's been a great resource. We've also had people ask about, getting third-party reimbursement from Medicare, Medicaid, or insurance through Circle of Friends. And we have not had the experience of anyone doing that. I guess one of the things we've said is, I guess if you made one of the criteria for eligibility for the group, a diagnosis of depression or anxiety, you could conceivably, have it reimbursed as a therapy kind of experience, but we don't know anyone who's tried that.
And the problem is not everyone may need qualify for depression or anxiety.
Exactly. So, so that just seems like not the most direct route, but.
And even when you're billing, it's for Medicare services, it's limited often.
Right.
Time span, so, you might be able to bill for a little bit, and the biggest thing with any new initiative or program is sustainability. And grantors we'll give you money for 2 years, but how are you gonna make this work afterwards?
Exactly.
And that's always what your goal is. A lot of times in my nonprofit world, I wear a lot of hats every day. And sometimes maybe we lost funding for a program, but we might be able to merge it in somewhere else to kind of try to keep it going a little bit until we find another revenue stream where we can help fund it. The ebb and flow in the nonprofit world is pretty heavy. I don't know, probably at U of M as well. I would guess that there's a lot of, because they invest in so much in the communities as well, and different programs like what we've been doing the last year.
And
I wanted to ask, you talked about the millage, is that the word?
Yes.
So is that
it's countywide and it's based on property tax.
yes,
But is
okay.
it a senior millage or is it
It's a
just
senior.
So that's what we have too.
Senior millage, yes, we all of the senior millages, we had a fact sheet, we were out advocating, and every place within the state that has asked for it has gotten it. So
So we have something similar in Missouri, but approved by at the county level. So 108 counties, 55, I think last I heard, have it. And in the city of St. Louis, we have multiple programs that are for Circle of Friends that are funded through that. It's called senior tax.
Okay.
And that has been a great source of support for that. And then our cognitive stimulation therapy program, we've got a partner in a rural county, and they've been funding their that program through their senior tax for years. 10 years.
Largely billing through OT.
Yes, yes.
So our local just got renewed. So
that's
it's
great.
good for 2 more years, and then we just got approved for another 10 years for senior services, which is huge for our area. And a lot of people don't realize how much is funded, legal services for seniors in Genesee County. Half of my meal program that my seniors get food is funded by the millage. You know, we would serve half the people if it weren't for the county funding that we receive. So the county really, and actually the commissioner this year, I mean, I want to say like $12 million are gonna go out. Don't quote me exact on that number, but it's over 10 million this year that are going out in grants just in Genesee County for senior services. That's a huge amount of money.
Right, and it's so much more cost effective to do it at the community level. And an ounce of prevention is worth a pound of cure.
Yeah.
Like, if they really sat down and did crunch the numbers, it would makes so much more sense. But what do I know?
We just started last year the transportation, just like you talked about, where the driver can sit with the person and bring them back, and they don't have to be in a car with 10 other people. It's an individual ride. The county is buying 3 new cars this year.
Mhm.
So they'll have 5, and 3 of them are vans that they ordered that are handicap accessible for wheelchairs. So transportation is a huge barrier in our automotive town that we
Yeah.
live in. Because, well, we didn't build the infrastructure for that.
There used to be infrastructure, and then when the auto industry came in,
Yeah.
they tore it out, because
Yeah.
Detroit used to have all kinds of infrastructure. They don't.
I want to make sure we have a little bit of time to talk about social prescribing. I'm curious, how many people have actually heard that term, social prescribing, before?
First I heard of it today in your questions.
Okay. Okay. Do you want to speak a little bit about that?
Sure. So and the term social prescribing has happened for a while, but I know it's gained more traction, especially in healthcare settings, and for providers who want to find meaningful activities for older adults. So really, it's a non-pharmacological connection to help individuals connect with community and other social resources. And, you know, we've been trying to implement a lot of this within our primary care clinics to train doctors, nurse practitioners, and care managers to find ways to almost write a non-medication script for older adults. So they're a little shocked when they see, oh, this isn't for a medication. No, this is for an actual, to a person, a navigator, or to a social resource in the community that you can get to. So if you look up the King's Fund from the UK, they've had a lot of work with cognitive stimulation therapy that we work with. They're actually implementing a lot in their healthcare system around social prescribing. Mentioned in the talk that social prescriber is actually a position or role that's gaining a lot more traction. Also, healthcare navigator has been synonymous with that. So it's basically any mental health, healthcare, allied health professional who's able to walk the patient, caregiver, family through the healthcare system to help them find more connections and gain more accountability when they go back to their provider or to their organization, that they're keeping the momentum active. Actually interviewed a licensed professional counselor at Family Healthcare Conference a few weeks ago in the UK. And he said they're starting to train even social work students, professional counseling students to adapt in these roles because of the big need for it in the community. So
Is it the same as the link worker? I was reading up a systematic review about.
It has, yeah,
Okay.
it has a lot of overlap as far as the mission and the roles for doing that. I think if you're working in more of a healthcare like integrated team where you have multiple disciplines, I think that prescriber can kind of absorb the recommendations from mental health, medicine, OT, wherever and kind of find a good plan for the patient and family to connect with. But there are also a lot in the community as well too, so they're kind of, flipping things out there, so just something to kind of think about, as we're still fairly medication centered in our healthcare system, so.
Well, and I think education is key to all of that.
Right.
Making sure that people who work within the healthcare systems and resources. One of the things I was just thinking about was in electronic health records, there's all kinds of those available, at least in the Epic system, which we're familiar with. There's the option to create a smart phrase. So we had one of the physicians created a smart phrase for one of our initiatives. And they click on it and it sends, in theory, it sends an automatic referral to the source, to the resource. So, making it easy for people to learn about them and to get those referrals made with kind of the next, which is the term warm handoff.
Yep.
So not just saying, oh, there's a service out there, go for it and fundraise.
So if you, I had a question, if you get a referral from that primary care physician or whoever, then you proactively reach out to the person. The action comes from you as opposed to you.
Yeah, the handoff, we've made that kind of a standardized warm handoff within our clinic system, so that if it's identified that someone's homebound, lonely, the provider is usually the first point of contact. Behavioral health or any other type of care specialist will fit in the last 5-10 minutes to be able to address that, kind of loop it back into their note. And then that becomes an ongoing goal that the whole team works together on in doing that. But to Marla's point, really, mainly the physicians, geriatricians, or those, they have to be the ones that identify in the first place to do that.
It would be nice, we work with the state of Michigan, the My Bridges, be nice to have more detailed information. If you apply for food assistance or Medicaid and there's someone over 60 in the household, it automatically kicks the AAA or referral in your area, which is great, but often they don't know what we're calling about. They don't realize that the system generated that and, they were asking for help here and we're calling over here. So I would say we're only at 50% success rate on reaching those people, but at least it is a link for us to at least get them in the database and at least have some information if they call in the future.
Absolutely.
I'm curious from the patient perspective, what have you heard? Term social prescribing and, what has this felt like for them?
Yeah, a great question. I think they kind of perceive it on their side as more of the opportunities for connection, and that their care team is more really supporting the mission for them to connect. They also feel relieved that they have a better open conversation, less stigma, knowing if I say something that's vulnerable, I'm not going to be given a medication. Or it's not going to elevate to depression. It's still, again, we talked about keep it in that somewhat gray area of, I want to make meaningful connections and I still want to get on do stuff. But a lot of patients are fearful of talking about that. So I think it's really opened up a lot more, to connect in doing that. And as we talked about, those questions can really allow that. But that was a big lesson. A lot of our young people was we had no idea. They weren't really divulging as much of their home life because they were thinking just, depression diagnosis. That was right on their radar. So, yeah.
Okay, can I ask another question? So are you at all involved with the CMS initiative now with the Alzheimer's Association about this navigation, the navigator?
We've heard of it, have been in a few meetings, so we have partners who have been involved in that and kind of carrying out some of the interventions around them. We haven't done anything specifically in their center.
Because my understanding and what I've read, and it's only been a little bit, was they are expecting those navigators to be volunteers. I know that was my exact reaction, like, oh, and that they're gonna follow the person through their 10 years of dealing with the diagnosis. Yeah, because in my National Council of Dementia Minds work, I facilitate a group of people living with dementia, and it's the first national non-for-profit that is run by people living with dementia. And one of the biggest problems is there's no warm handoff.
Yeah.
They get a diagnosis, they get handed a brochure, and then we'll see you in 6 months.
Right.
Yeah, it's a great point.
Comment from Bridget in chat. She said, so I'm listening to this and hearing about providers, but many people do not see the same doctor each time. They go into the office and the consistency of care is not great. What are your thoughts on this?
Yeah, so I should have put the disclaimer, it's never a perfect science. When you're doing this, it is a good point. I would say, yes, mainly the buy-in is not only kind of from individual providers, but I think if a team talks about it together, I think that's kind of a broader mission of where they're going with kind of their social prescribing mission or alternative that they can help with their patient. But I think it's still important wherever it is, even if a main provider, if they kind of providers seek around town, that the behavioral health, allied health, and other specialists in the clinic can really have that connection piece on the forefront, even if the providers don't know that heads on. So, and I think that's where the handoffs and more of integrated care really has to elevate to be able to fill in this issue. Because if they just leave it to the doctor or one-to-one conversations, these conversations are largely never going to happen.
And sometimes don't you find if you can just start with one champion that you find.
Exactly.
It all starts small. You can't always think of everything as, you know, just gonna hit the ground, and it starts with just one person, one thing, one individual, and then you grow it from there. And when you get a few champions in your corner.
And what our champions tell us is persistence.
Yep.
Yeah.
So we always look for those champions when we're working with we have 2 new partners in currently, and we're looking for the champions there, and have been told by our experienced champions that you have to keep going back and back and back and back until it finally catches on.
Till it sinks in, yeah.
Yeah, exactly.
Am I allowed to ask a question real quick?
Yes.
I was gonna just send for both of your programs of work, what's been kind of the secret sauce as far as what's been sustainable, the most sustainable programs over time, what kind of the common element that you felt has really helped?
Well, to be honest, a lot of our evidence-based programs are at our senior centers. And our more active senior centers are the ones that were usually more successful. And even despite all that, like we talked about, I heard a couple students ask questions about it. I find that the seniors that are engaged and go out and are more mobile, they'll continue to do that, trying to reach those isolated people that are at home, that maybe there's a lot of barriers why they don't come out. Incontinence is a big issue with people in public with seniors that they don't want to talk about, and they don't often go out for meals because of that. So a lot of factors, you know, which deter them to come to the centers to participate in those types of things. So what we try to do is go where the senior is, start where they are.
Yeah.
Wherever that may be. Sometimes it's a church, sometimes it's a senior center. The day program, we even, we do a lot of art therapy at our adult foster centers, which are like assisted living for seniors. So different things like that.
For us at a senior center that's really vibrant, it's the role of the volunteers. We have this level of commitment and they have this pride in participation, and they really work on relationship building. So that connection is made and there's this trust factor. But it's the continual recruitment and fostering of those volunteers. I mean, I have never worked with a group of people as exemplary as these. 70% of my volunteers are retired nurses.
Have you found a big drop off in your volunteerism since COVID?
No,
Yeah,
actually,
clear. It's
quite
been hard.
the opposite where we are. Because there's more people retiring and they're really looking for meaning and purpose. Also.
Genesee County.
And well, as NR gets more expensive, there might be an influx.
Yeah.
The other thing is that the senior center really listens to cares and concerns and and the programming reflects that. So square dancing is one. We actually had this one member who loved square dancing and according to her, world peace could come with everyone learn to square dance. And she brought it to our group at Ease the Day first, and it caught on. And so now they have square dance every week. And so it just builds this loyalty and then the senior center becomes a point of contact. So we network with the other community resources that would help these people. And I think having a variety available, like, because it's group, but an individual need. And so really the scope of what is offered, it's really hard not to find something that speaks to you. And getting people through the door is really what we're all about. The other idea on this idea of building skills and new learning. I mean, I don't know if anybody's familiar with Ashton Applewhite and this chair rocks the Manifesto Against Ageism. She's quite amazing, but this whole idea of these stigmas that we have about age, but the fact is that anyone can learn something new. You never lose that skill, just what you can handle cognitively, but new learning and skill building. Like I had my 97-year-old participant never played ping pong before, at least that she could remember. And she played it for the first time. She had such a good time. So,
Our time is up, but we, Ken, do you want to do closing remarks or?
Sure.
Okay, I will say quickly before Ken comes down here, thank you all so much. It's really engaging conversation that can go on for hours, which is wonderful.
Many in the chat, thank you, so this has been really valuable information, so I wanted to share that.
Thank you, Helen. You can go, Ken.
Echo the thanks to our guests today. Thank you for traveling so far to get here. And this is exactly the kind of intellectual exchange that the center envisioned when it started, when Dr. Goldberg applied for funding from the Breyer Family Foundation to start this community. It's inspiring to learn about your research on social isolation and circular limbs. I'm really curious about cognitive stimulation therapy as well. It's been a challenging time for all of us to adjust to hybrid work lives, I think. And it's got us thinking about these kinds of technological tools, reducing the barriers for care for older adults and for social interaction. Earlier this week, I actually saw there was a presentation here on campus by some representatives of Apple who brought a presentation talking about the Vision Pro. And I was fascinated because instead of a mouse, right, you can just put this headset on and just start playing with visual imagery in front of you. And apropos to your comment about older adults learning new things, I was thinking about that in addition to this. So we are an institution that might be considered an emerging research institution. We're certainly on a path to have more research activity in the next few years. And our office is very excited to continue to support the center as it builds community and engagement around the study of aging. Having visiting scholars like Marla and Max is exactly the affirmation that we need to continue to build community on our campus and for us to make our own novel contributions to aging research. So please join me in thanking our guests. We look forward to them.
Thank you.
gonna say, I'll give you my card and if you ever want it.
It's sitting up on the. Feel it for my hands.
Oh, okay.
So you can have.
We got the policy.